Welcome to the pitch. My name is Anthony Viscogliosi, and I will be your moderator for the pitch. As a reminder, this is a monthly program, and it's scheduled for the second Thursday of each month at 7 p.m. Eastern Time. At each program, we present two promising companies that present their technology and their business plans live to our presenters. To watch last month's program clips, please visit ryortho.com. ryortho.com. With that, our presenting company for this episode is a firm named Transcendent Care. This company hopes to give spine surgeons artificial intelligence and a deep learning tool which they can use to better diagnose pain generators faster and more accurately than the current standard of care. Could an artificial intelligence tool accomplish such an ambitious goal? Well, we're going to find out. Here is Transcendent Care's pitch.
Hello, my name is Michael Verdon. I'm a neurosurgeon. I am the co-founder and chief medical officer of Transcendent Care Incorporated. Along with my partner, Rob Capzello, we aim to make point-of-care diagnostics for spinal pain patients and their physicians. This is important because it is a very common problem. It's a leading cause of disability worldwide. 80% of all adults experience back pain at least once in their life. It's extremely expensive care, accounting for 60% of all medical dollars spent in the United States annually. More importantly, if you're a patient with back and leg pain, could you imagine if you get referred to your doctor to someone who doesn't even take care of this problem? You can waste 6, 8, maybe 12 or longer weeks trying to get to the right provider. Worse yet, could you imagine spending 10 to 15 years of your adult life training in order to help these people and constantly or consistently seeing patients who do not need your help? The current state of care in the United States is it's a $90 billion spend annually. That's with a B. 30% of all patients who interact with the healthcare system improve after treatment. That leaves up to $60 billion annually in low value or wasted care dollars. Our goal is to develop a technology-based tool which can match the right patient with the right physician for the right treatment at the right time. This is built by physicians for patients and all clinicians.
Hi, I'm Rob Capzello, Dr. Verdon's partner and Chief Executive Officer of Transcendent Care. My background is in the design and delivery of commercial data and analytics solutions. So how are we different? I was initially struck by the difference in Dr. Verdon's outcomes, some of the best in the country. What could we learn in order to create simple, transformative solutions to relieve people's pain? Central to our approach is the data. We designed our products around 4 key data-centric concepts we felt were necessary to tackle the problem. 1, a consistent assessment. 2, leveraging the power of AI. 3, sharing patient learnings. And 4, democratizing or sharing medical knowledge. So how do we do this? Our current products address 2 problems. 1, directing patients to the right provider, and 2, improving diagnostic accuracy. Neurosurgeons are frustrated. Many see 20, 25 patients before converting one to surgery. Many could easily be treated by other providers or their own primary care physician. Our easy-to-use triage product rapidly identifies patients who can benefit from surgical intervention while suggesting more appropriate providers to those not needing surgery. Our diagnostic product significantly reduces time for both patients and physicians. Its precision, individualized, multidisciplinary assessment collects just the right clinical data, then uses AI to rapidly compare with other patient experiences to render diagnostic insight. Our products are delivered using a B2B SaaS model. They're data-focused, cloud-based, and multi-tenant ready. Our initial market focus is neuro and multi-specialty orthospine surgical practices, and expansion opportunities are next in the conservative interventional practices, and eventually anyone who treats back pain. We will leverage existing distribution channels and the other significant opportunity we feel in the data markets. Pricing is conservative and margins are strong due to our technical architecture and our business model.
Medicine is indeed entering a brave new world of digital care and digital innovation. Joining us from Transcendent Care are its co-founder and chief medical officer, Dr. Michael Verdon, and its co-founder and chief executive officer, Rob Capizzello. Capizzello is maybe a little difficult name to say sometimes. I know a little bit about saying a difficult family name. Rob and Dr. Verdon, we're very delighted to have you with us. Welcome to the pitch. Now, let's turn the program over to our panelists and ask them to interrogate Transcendent Care. And we'll start our panel section with Dr. Paul Anderson to give us some view of how a clinician who's an orthopedic surgeon specializing in this area could use this kind of technology and what it offers to the physician. Paul, we'll turn it to you.
Yeah, thank you. Michael, I agree with your goals of treatment. And I really like the phrase about the right patient to the right provider at the right time. And I share your frustration. And obviously a quality improvement goal is to provide similar care to all patients with that condition. And I can see how AI may help in that effort. And so I think this has some potential. My question is, what data points are you using in this triage system, as well as trying to decide what kind of treatments you might institute?
Interestingly enough, the triage bot came about some teammate requests to see more surgical patients or more patients that needed him. And we took a couple of randomized trials where they had a paper version of a triage model. And we scaled that out and used bot technology to create a questionnaire that would generate a score and put a patient in a box and say you're high, medium, or low risk for surgery for a spine surgery in the next 1 year based on statistical data. And that's the way the triage bot presents. We also were worried about things being missed. You know, triage mechanism for especially for spine patients, the community can be scary. So we were worried about concepts like myelopathy or emergencies. We built a series of questionnaire in there with hard stops to direct patients to the appropriate level of care. The data points that we used from the spinal app or the diagnostic side were kind of typical classic old school teaching diagnostic points in terms of pain patterns, dermatomal pain patterns, musculoskeletal changes in strength testing, sensory loss, and just the basic things that you've probably passed on to residents for years on how to do a basic spinal examination. We were able to form that in such a way that we create a data set which is capable of being utilized through machine learning. When I started the process, what we recognized is none of the data was able to be called in a machine learning model because all of the data is in free text, essentially, in most EHRs, in my opinion, or it's an HL7 billing data. So there's really no clinical tool or clinical data set that allows you to independently come up with a clinical diagnosis. We were asked prior before this, what was that about for us? Were we willing to use free data? And the answer is we considered using models like natural language processing, but ultimately that most of the EHR data that's probably been collected over the last 15 years is essentially free text. The real benefit, in my opinion, Dr. Anderson, is we now can standardize a simple exam. So everybody gets the same exam all the time. And quite honestly, in spinal decision making, the exams are everywhere. How many different ways are there to do a laminectomy? How many different ways are there to do a knee replacement? There's like one, but there's 1,000 different ways to examine a spine patient. And that's where I think the quality starts to go away. And we started with this: what are the basic tenets of a diagnosis, and let's build from there. What are the basic tenets of a patient who require surgery, and let's build from there. So that we found this to be predictable and useful.
Yeah. Is this this exam that you do, is this put in the medical record in a form that can be then abstracted to your bot program, or does this have to go into the bot directly by the physician, presumably, or a physician's aide?
Rob, do you want to handle that question, or I can tell you the workflow for me clinically, but
Yeah, sure.
go ahead.
I was going to say the good news is it comes directly from the patient. So the triage bot was designed to do exactly that, to use patient input. And yes, it does create a mechanism to append itself to the EHR.
But Michael was talking about physical exam findings and things as being part of this.
Well,
patient can't do that.
So the biggest portion of this is their history.
Oh, I
History
agree. 90% of the diagnosis.
So patients usually come to me with no history taken, and 90% of the diagnosis, like you just said, can be determined by the history. So the very first portion we create was a robust history taking, basically an algorithm which can predict which potential diagnosis these patients have. In the community right now, you have back pain, go see the spine surgeon. That's not what it was 15 years ago. And now we have people who have very little clinical experience, or their mid-level providers are essentially triaging the patients anyway. So for me as a surgeon trying to run a clinic and be productive, I can't be the triage nurse for a region. I have to have that patient called, and the very simple way to do that is question and answers, and they're very powerful. That, I guess I misspoke about the objective portion of that. I apologize.
Yeah, I would say, to me, what is actually maybe more important than trying to get the surgeons to agree on a pathway would actually work on primary care, because they don't know what they're doing at all. And, if they send me a patient with back pain, that patient may actually have a cervical spine problem or an open tibia fracture. I mean, they can't tell the difference. So it would be better to work on, personally, it would be better to try to standardize the exam, the history from a primary care perspective, because that's, I think, where a bigger part of the system is failing. That'll be my last question, but you can comment on what you think about that.
100%. I agree 100%. I feel like in my community, like I said, I'm the back pain primary care doctor. It's not a matter of the surgeons using it or not. It's a matter of taking surgical clinical expertise and putting it into the cloud, or putting it into a web-based platform, or put it wherever the patient can get it at. If the primary care physician, some of them feel like they don't need that help. We're trying to provide this to the patients and to people treating those folks. We'd be happy to work with anybody who's seeing these patients, and we know that that's the #1 cause for the visit to a physician is back pain for an adult. So we think that they're a market as well. Large one, a very large one.
Dr. Anderson and Dr. Verdin, thank you very much for your questions and your answers thus far. I have 2 basic questions I'd like to ask at this moment before we turn it to our next panelist. And Rob and Michael, who do you sell this to, and what do they pay for it?
Rob?
Yeah, well, we're currently in beta mode, so right now it is free. The intention is to sell it based on a provider subscription, and all of our financial projections right now are based on a very modest $2,500 per provider annual subscription. So we feel like, to Paul's point, we can get all the way eventually to primary cares, but really start focusing with the neuro and ortho spine folks to really build credibility with the product and refine our models, and then move into the the more conservative interventional providers, and then go to the primary care.
Okay, thank you for that. Before I chew up too much time, let's turn it over to our next panelist, Audrey. And Audrey, the floor is yours for some Q&A.
Thanks, Tony. And gentlemen, congratulations on what looks like to be a very valuable and important tool from a number of perspectives. I have a few questions, business related ones, but first I want to understand how many patients your current beta version is based on, patient data wise, and how many patients do you hope to have incorporated data wise before you release to a more general population?
Yeah, currently we're probably in the hundreds, 500-600 patients. We'd like to be in the more around the 10,000, 20,000 range. We feel like we need that to further test our models, refine the assessment too where needed. But we feel like we need to get to that sort of volume to really feel confident.
Sure. And the 500 that are in your beta version, are they a tight collection of patients, or like how many providers were included?
Yeah, currently we've got 3 providers in our beta program, and we're hoping to have, we're shooting for 10, at least 10 providers. We've got 2, and hopefully we'll be signing on another one here in the next 30 days.
Okay, so if I understand correctly, the main output here is to help direct the patient to the proper caregiver for this stage of their affliction. So therefore it's not a diagnostic tool, is that correct?
That is correct.
Yeah,
Okay.
We have 2 tools. We have a triage bot, which is immediately available to help ease the burden of the glut of for me, non-surgical patients in my office, which takes up a lot of time and energy. For the patients, it's to get them to the right treater, to get them right treatment, to get them better quicker. So there's an immediate benefit there. Through those patients that the Rob spoke of the numbers for, model validation. Diagnostics are able to be predicted right now if we have, but we're worried about statistical validity. So we wouldn't roll that out because it really wouldn't be the right thing to do at the moment. However, we have the capacity to turn that on with patients today. We just choose not to share that because, quite honestly, we're not sure of statistical accuracy of that, and we wouldn't want to have a point of care tool that's not statistically relevant or statistically accurate.
Sure, and that makes sense. So from what you've said so far, it sounds to me like you're not considering a regulatory path. But if you are, I'd love to hear what you've got planned from a regulatory perspective.
Yeah, currently we're not assuming that.
Okay.
We've discussed that at length. Software as a medical device obviously is what we're thinking about. The possibility of that would be with the diagnostics, not triage bot. I think it's really an efficacy standpoint. My personal opinion is I'm ready to climb that mountain if it has to be done. My concern is the market may never embrace it as truly a medical device. And I'm not sure if the physicians will embrace it as truly a medical device. Will it have an impact? Yes. But I don't know. I don't know. We're open to that. But from where we stand right now, that's not in the plan.
Okay. Yeah, I know it's still an evolving area. What constitutes software as a medical device? A lot of companies who are heading down that path are still having, pre-submission meetings with the FDA to really make sure that the direction they're headed is aligned with how the FDA would see it. So yeah, it sounds like your current direction is a good one. Here's a question in terms of patient applicability. Would you see this being used primarily on patients who are coming to a neurosurgeon or orthopedic surgeon for the first time for back pain, or would it be applicable to patients who are repeat visitors?
We made it for multiple episodes per care per patient, because really in the practice of medicine, you see patients and you see how they respond to care. So you get an intervention and your symptoms change. We actually want that knowledge to be called so the patient physical experience of their disease state is mapped and the models are able to learn from that. So it's a multiple encounter tool. It's not a one-off kind of thing.
Okay.
We really think that there is value there in the assessment tool of somewhat of a snapshot, right? So it's taking a snapshot on the first visit, but it's the same evaluation that you would do on subsequent visits. So it does give you that sort of snapshot in time to see how the patient is progressing.
Great. And maybe one last question before I turn it back. And that is, how are you taking into account outcomes from whatever the treatment path that was chosen was, and kind of sanity checking that initial direction to the patient?
Well, when outcome scores are scores that I use in the office every day that we put in their simple measures, VAS, and what my version of an outcome is, when outcomes are measured as not an infection or not something bad, that's not an outcome. That's just a poor outcome that's being measured. So I don't think outcome measures as not an infection as a successful treatment. My concept and our goal is symptom resolution is a positive outcome. So that's how we're measuring the treatments that are being applied to the patient. So outcomes measure, in my estimation, are not worth measuring. You should not want that to happen. That should not something you should. It's great to say to someone, I have a 10% infection rate. No, it should be 0. Why? What? So what we're trying to say is we're trying to get to symptom resolution, not the way we currently manage poor outcomes. If that makes any sense.
It does, although I would think symptom resolution would be maybe the most important outcome.
It is, but it's not something people are metriced on for quality right now. The insurance companies don't pay you on that, which is craziness.
All right.
Well,
Thank you.
Audrey, thank you very much. And Dr. Verdin, again, thank you very much for your commentary thus far. And before we get to any more craziness, let's move to our next panelist, who is an innovator himself. And let's try to think a little bit about how innovative this is. So Mike Sherman, let's turn it over to you.
Thanks, Tony. And look, again, congratulations. I recently had the opportunity to visit my local spine doctor and spent the first probably 10 minutes sitting in front of a computer screen answering questions that probably represented like a neck disability index and other things. And it was all reasonable stuff and all stuff that I think I've read about in journals. But does this tool, whether it's the triage tool or your other tools, do you incorporate some of the classic validated tools that exist? I would imagine you do. But.
Yeah, actually, you talked about the neck disability index. We use the modified JOA to pick up on spondylitic patients and myelopathy patients that are very silent, that would silently present to us. And we actually were talking about this yesterday on our clinical call that, hey, that's the real meat for uncovering silent clinical myelopathy. And me and the other docs were kind of amazed about how, if you have this tool and the patients answer these questions, the patient can come from lumbar radiculopathy and have bad cervical myelopathy. You will never pick it up unless you're really paying attention or you do the same thing all the time. So yes, that's the goal, is to take all those wonderful scales and use the information in real time. And that's why we scaled this the way that we did, because we want to use the tools to help you and the doc pick up what's going on with you. And right now it's just a scale that goes into a chart or it goes into a report or a paper. That is not useful to you or to me.
Right. And then I guess over a series of visits, you could, just like if you look at blood work on a portal these days, you can get a a graph of how you're trying to.
100%. So I measure an ODI for patients all the time, right? And the first thing I look at is, what is a high or low? Where are you? And I mean, maybe 2 weeks post-op, it's not come down low, but I know the patients who get surgery in 3 months, they should be pretty close to low, or they have underlying comorbidities that won't let it come down. So in some ways, we were asked about outcomes before. I know my treatment options are working if those ODI numbers are going down for those patients. And we measure all of that inside of the app. Same with VAS and all these other things. So you have some kind of like temperature gauges for us as surgeons. That a VAS is a temperature gauge, what you're paying, right? Or ODI or neck disability index. So we have ways you can see that pattern, and the machine presents the pattern. It records it and presents it in a way that's functional to the doc. I'm always learning. I'm always learning about what I do. I'm always learning about how to become better. I'm always learning about a new technology, always learning. So I need to collect information. I'm getting old. I can't hold it in my brain anymore. And that's what this helps me to become better at. And I'm grateful for that. I mean, look, if Jeff Bezos knows what I've bought for the past 15 years, there's no way I can't use the same technology to make a better diagnosis for my patients. That's not reasonable. And that's where we started with this. And I still stand. We are going to get there because it's possible to take that technology and point it at something that's useful. And that's what this is, if you ask me.
I'm going to leave it there. That was a great summation. I think I have no more questions. Thanks. Thank you, gentlemen, and thank you, Tony.
Thank you very much.
Thank you.
Well, Mike, thank you very much for your questions. And I'll wrap up with 1 or 2 questions and comments. So the digital medical technology world is moving very, very rapidly,
Yes.
changing, weekly. And with this rapid change, how are you designing the ability to protect what you are doing in the creation of value? How do you protect the value of what you're doing?
Yeah, I'll answer that. I think it's certainly about the data, right? And how we handle the data, how we identify clinically relevant pieces of data versus the things that really aren't. And again, this is why we chose not to go the EMR route, trying to pull those things in and uniquely using machine learning models to ferret those things out and to prove that they're accurate. Honestly, that's what got me interested in this. If we couldn't be in the 70-80% accuracy level with this data that could predict or suggest a diagnosis, then I saw no reason to build an application around it. And once we were able to achieve that, like, okay, let's go. So I think we do have that unique abilities to synthesize data coming in, very easy to incorporate social determinants, imaging data, any other type of data into our data set and to iterate again. Have we proved it even further? Have we gotten worse in our model, our recommendations? So I think we've got a unique machine, so to speak, to be able to do that.
And will you own all this data and share that ownership with the physician's practice that you're licensing the software to?
Yes, I don't believe we will own it. They will own it. They'll own their own data.
Right. But you won't own the data then?
Correct. But we'll own our models. We own, and that's what would be more proprietary. And the process by which we create those models and synthesize that data is very unique.
Wonderful. Thank you very much for this thoughtful interaction. Each of our panel members and Michael, to you and Rob. Now, audience, what do you think about this? From what you've heard thus far, is this a winner and a game changer? Or does this company need to go back to the drawing board? We now will turn the program over to Robin Young. Robin is publisher of Orthopedics This Week. He will conduct our polling. Robin, over to you.
Great. Thank you, Tony. And I have to say that was a fascinating discussion. And I agree. Digital technologies are improving weekly. Okay, let's put up our poll, and really great discussion. So what do you think? Transcendent Care, using AI to triage, and you heard the neurosurgeons just talk amongst themselves, and they jumped on this thing right away as a valuable tool, a real time saver. Could it challenge standard of care? As if, and I think the standard of care is pretty loosey-goosey right now. There isn't really a true bot, AI-driven triage program right now. Okay, and how do our answers look? Pretty interesting. Okay, so yeah, about 60% think it needs more work. It's promising. There's something here, but hard to see. And an equal number, interestingly enough, 29% winner and future game changer. So, and this is, I'm sure this represents this sort of this period of transition that we're in right now, trying to understand database products as opposed to an implant type product. Great job, everybody. And audience, as always, it is just, we couldn't do this without you. And with that, I will wish everyone a good evening. And thanks to our panel and our two companies for their presentations.